Hi, my name is Brent Beasley, the Medical Director for St. Luke's Care, and today we have Greg Howell with us today. Greg is a pulmonary critical care physician in the St. Luke's Health System. We invited Greg today because Greg himself has been doing some presentations on critical care medicine for our health system recently. As well, St. Luke's Care's critical care evidence-based practice team has created some new order sets for the health system to use that we thought might be valuable to go through and discuss, in addition to also discussing the recent literature that supports some of these endeavors. So Greg, welcome. We're glad you're able to be with us today.
Pleasure to be here.
Let's go ahead and get started. I want to start off quickly with mechanical ventilation. So a new order set that just passed by the St. Luke's Care evidence-based practice team. So the date on this that's come out is April 4th. And it kind of takes a physician in the critical care setting through just putting a patient on a basic ventilator. Greg, are there some things about this order set and or the recent literature that you wanted to kind of point out about mechanical ventilation?
Yeah, I think there's quite a few very interesting and very helpful things on this order set. First off, it really puts an emphasis on the very top of the page, and for instance, under ventilator settings, number 1, talking about more of a lung protective strategy of mechanical ventilation. Recently, there's been, lots and lots of data talking about, volutrauma and barotrauma, and there is a separation between those things. Volutrauma is a clinically significant problem that is independent of barotrauma. One would think intuitively that as volumes in the lungs go up, pressure in the lungs go up, and therefore volutrauma and barotrauma are identical. And actually, if volume or pressure is kept constant in the setting of a pressure controlled ventilation setting or a APRV setting, we do find that patients are having injury from tidal volumes in and of themselves that are independent of pressure. So starting off with figuring out that we need people on 6 to 8 milliliters of tidal volume of ideal body weight is really important. The ideal body weight thing is actually very important because if you looked at even back at the ARDS-NET trial, one of the main criticisms, actually one of the criticisms that was published by another UMKC professor, Dr. Salzman, was that the ARDS-NET compared 6 milliliters to 12 milliliters of tidal volume. And Dr. Salzman's editorial in the New England Journal would have said that this trial is helpful, but not that helpful because we already knew 12 milliliters per kilogram would be injurious at the time that was done. But the ARDS-NET investigators had actually reviewed, broadly across the country what was being used, and when physicians thought that they were using 8 to 10 milliliters per kilogram, they were using actual body weight. Well, in our country, actual body weight is not usually consistent with ideal body weight. The obesity epidemic, etc., was showing that indeed at the time of the ARDS-NET trial, people were actually using 12 milliliters per kilogram of ideal body weight. So keeping tidal volumes in mind with ideal body weight, which is calculated by height, is the way to do it. As somebody gets heavier, their lungs shouldn't get bigger. So they won't get bigger, as a matter of fact. And using 6 to 8 kilograms of ideal body weight is very, very important. The respiratory treatments section, I routinely don't necessarily use bronchodilators on every single person, but as you know, the overwhelming majority of our patients will have some sort of smoking history where using either albuterol or a combination of albuterol and ipratropium will help not only with bronchospasm, but with mucociliary clearance. And then the other parts of it seem fairly straightforward, talking about ICU prophylaxis and monitoring with chest x-rays and blood gases, etc. I think it's a pretty solid order set. I think it's inclusive, and which is also very nice is it's only on one page, which makes it obviously much more user-friendly.
Greg, you mind talking just a little bit on, in the ICU setting, the DVT prophylaxis? Are there some issues that come up there particular to the ICU setting that a physician would want to stop and think about when they're using this particular order set? Right now, there's a DVT prophylaxis order set that this is bundled with, and so a physician getting that bundle, coming up with the DVT order set, looking at it, are some of the major issues that you're dealing with in the ICU about that?
The main things that we deal with are post-operative patients. When do we start ICU prophylaxis after somebody's had, a brain lesion or an abdominal issue or a thoracotomy, those types of things. As far as particular differences between one we use enoxaparin 40 milligrams once a day versus 30 milligrams twice a day versus heparin 5,000 units 3 times a day, a lot of that does come down to clinical practice, the particular clinician, what they feel more comfortable with. I am pretty comfortable with, I think that the enoxaparin, usually, I do believe that there's less heparin-induced thrombocytopenia associated with it. And the 30 milligrams twice a day is probably a little bit more valid in our morbidly obese patients. There's it's harder to get therapeutic levels in them when you're using subcutaneous. An interesting thing where some of these order sets are using heparin 5,000 Q8 hours. We recently had a Journal Club article where we were reviewing heparin 5,000 Q12 versus heparin 5,000 Q8 versus another one of the unfractionated heparins, and they found that the heparin 5,000 Q12 is probably as effective as Q8, so that might be something we can look at in the future.
That's great. Mm-hmm. The other thing that's come up recently is this issue about GI prophylaxis. Mm-hmm. So a lot of our ventilated patients need to be on GI prophylaxis. Yes. We also find that it doesn't get stopped once the patient comes off the ventilator and goes to the floor. So we find that we're spending a lot of money on GI prophylaxis that's not indicated. Your experience?
Mirrors exactly what you've just said. I mean, there not only are patients going out of the ICU on GI prophylaxis, and usually a PPI, not an H2 blocker, which is even more expensive, but then they're even getting sent home on GI prophylaxis when they've never had any sort of peptic ulcer disease, gastroesophageal reflux disease, or any other indication for prophylaxis. So having some kind of stop triggers on these types of things, DC went off of mechanical ventilation, or reevaluate need for continuance after dismissal from the intensive care unit, I think would be helpful. In my eyes, the main areas where GI prophylaxis is indicated is active coronary disease in a mechanically ventilated patient, where they're on the ventilator for more than 24 hours. That's where our strongest evidence is for it. Past that, I totally agree with you that we are probably overusing it.
Okay, let's move on to the next one. This is the analgesia sedation orders for mechanically ventilated patients. Sometimes we're trying to get the patient off the ventilator, but they become very restless, they become very agitated, and so it almost seems like we're going to catch-22. We want to keep them sedated so they don't get agitated and restless. At the same time, we want to wake them up and get them off the ventilator. Can you, as you're going through that, kind of address that question as well as we're going through this order set?
This new order set, we've been using this, or an iteration of this, for a few months now, and I really think it's very good. I think addressing your first concern would be under Order 1A, where we actually are starting with, bolus doses, intermittent bolus doses of, the opioid analgesic, in this case, fentanyl or Dilaudid or morphine, Q30 minutes PRN for pain. And then similarly, we're using bolus doses to start off with Ativan or lorazepam, as talking about addressing number 2. Oversedation in the intensive care unit is a big deal because it does lead to increased ventilator days, increased ICU days, and then extrapolating from that, increased complications from being in the ICU, whether it's a ventilator-associated pneumonia, a DVT, a stress ulcer, whatever complications come up. ICU delirium.